And I am setting up for us to go live on Facebook. It'll take 2 seconds. Hey guys, I'm going to hit it and then it'll be a 30-second. Good evening, everyone, and welcome to our Facebook Live as part of our Heart for PCOS campaign. We have a superstar panel with us tonight, everyone, and so excited to have them with us to talk all about PCOS and trying to conceive and infertility and pregnancy and what that means for patients with PCOS. So I would like to first introduce this wonderful panel, and I'm going to start with Laney. Hi, Laney. How are you?
Hi, Ashley. Thank you so much for having me on here. I am the Director of Communication and Engagement for the Preeclampsia Foundation. And along with my professional career, I also am a patient of IVF. I never experienced PCOS, but I have a really strong heart for helping represent lost moms and making sure that there is a lot of hope in this field and helping to connect the research to patients that are in our audience today. So thank you, Ashley, for the opportunity to talk about this intersection.
And thank you for joining us. And Shawn, hi, how are you?
I'm good. Hey, I'm Shawn. I'm a gynecologist in Austin, Texas. I've been in practice for about 20 plus years. Haven't delivered a baby in about 7, but I think I've done a few in my career. And I have some integrated medicine background. I did a fellowship at the University of Arizona. So just kind of trying to blend, the research on both sides, bring it to my patients here in Austin.
Awesome. And can't wait to hear your take on things this evening. Serena, hello.
Hi, Ashley. My name is Serena Chen. Thanks for having me. I'm a reproductive endocrinologist in New Jersey. I'm the director of the division at 2 different hospitals and a clinical associate professor at both Rodgers, New Jersey medical schools. And I'm excited to be talking about PCOS because we all have so many patients that present challenges and we'd love to help them.
Awesome. Thank you so much. I can't wait to hear everything that you have for everyone this evening. And Blake, hi, how are you?
I am doing great. How are you?
Wonderful. Thank you. So excited to have you here this evening.
Yeah, thank you for having me. I appreciate it. So I'm Blake Evans. I am a reproductive endocrinology and infertility specialist at the University of Oklahoma. So I'm assistant professor there. I also have not delivered a baby in quite some time, similar to Shawn. I am board certified in OBGYN as well, but now I help make babies. And so I have a special interest in PCOS, kind of on a personal note, and I did get permission to share this, but my wife has PCOS, and so we had to struggle with infertility treatments as well. So I can definitely relate, although I obviously personally do not have PCOS.
Well, I'm really excited that you're here and thank you for sharing that story with us. Hi, Allison. How are you?
Good. Thank you so much for having me. I agree. This is like a superstar panel and I'm like honored to be part of it. So my name is Dr. Allison Rodgers. I'm also a reproductive endocrinologist and infertility specialist. I am at Fertility Centers of Illinois in the Chicagoland area. And I obviously, just like everyone else on this panel who sees patients, I have a lot of patients with PCOS. I am a big believer in sort of fertility at every size. I also am really, invested and involved with managing patients through their fertility journey who experience sort of the range of the PCOS spectrum. So I'm really excited to be here sharing all of this with you guys today.
Thank you so much. I'm so excited too. I wanted to start with a big question because I feel it's a question that comes up a lot and a lot of controversy around it. So, why not start off with a hot topic, right? I wanted to find out from each of you. Many patients hear that you can't get pregnant with PCOS. So how true is it? Is it just that it's difficult or that it's just something that people have associated with PCOS? Why do we have this message out there so much? Allison, I'm going to start with you.
So I think that it's really important to know that nobody should tell anybody they can't get pregnant. But in general, people who have PCOS often either aren't ovulating or aren't ovulating regularly. And certainly the three things you need to have a baby are sperm, eggs, and a uterus. And if you're not releasing eggs, there's less chances to get pregnant. And we talk, I really think everyone on here can talk through this like spectrum of PCOS, right? We have patients who ovulate every month and have a little bit of this sort of hormone imbalance where they have a little bit of extra hormones and they're having a little extra hair growth and they have some extra eggs and maybe don't produce enough progesterone when they ovulate, but they're probably ovulating. And then we have like people on the very opposite side of the spectrum who never ovulate and have, maybe never get a period. So I really think that like putting a blanket statement out that says you can't get pregnant is really not okay, of course, and it doesn't apply to everybody. But I do think it's true that a lot of people who have PCOS don't ovulate regularly and need help getting pregnant, but not everybody. We got lots of patients who get pregnant on their own just fine.
Absolutely. And I'm glad that you're sharing that message, because I think it's vital when people go into this, that they have some sort of hope and realization that it might be difficult, but it's not impossible. Shawn, how about you? What are your thoughts on this?
I totally agree. I think that it's a tagline that is a myth that's being propagated from eons ago. And I'll be the first to admit, our family dealt with PCOS and even miscarriage. But with women that don't ovulate, as was just mentioned, obviously it's kind of hard to get pregnant. But even women that don't ovulate, I think, and my REI colleagues probably know this much better than I do, but it's about 75% of them with Clomid will ovulate, and I think the conception rates are over 25%, even with those patients. So, and I get that all the time. Women that come in with PCOS will say, "Oh, I was told I can't get pregnant," and I was like, "Well, then you're going to get pregnant because you've been told you can't get pregnant," and which is what she just said. So yeah, it's not a infertility sentence. It's definitely something that you can work with. A lot of women can even change things, sometimes with diet, sometimes they need extra help, which is what we have my colleagues for.
Absolutely.
And I think, from the side of having been through infertility treatments, the science is amazing. What doctors like Dr. Chen and Dr. Blake do is just really, really amazing. And we understand quite a bit about the way that a hormone cycle needs to run. And so there's just lots of interventions from mild treatments to more, labor intensive processes, but it's certainly something that every patient with PCOS should have hope that if you would like to have a child, you can definitely have a child.
Yep. I love that message. Dr. Blake, what are your thoughts?
Yeah, I'm just thinking of, of all the spectrum of patients that I see on a regular basis with infertility. I don't know about the other physicians here, but I almost see it as kind of like a breath of fresh air when I see a patient and I diagnose them. I'm like, oh, it's just PCOS. This is easily, we can treat this, we can get you pregnant. And of course, I don't mean to say, oh, it's just PCOS, but I say that in terms of more reassurance, because if it's just straight up PCOS, sperm's normal, tubes are patent or open, and it's just a matter of getting you to ovulate, that's an easy fix. And I have a lot of hope and reassurance for patients like that. So definitely, I never say, oh, you cannot get pregnant if you have PCOS. And like I said, my wife and I dealt with it. We've got 2 kids. So and I'm not just the only one who has successfully had children with PCOS, but nonetheless, again, it's reassuring to know that it's something that's very easily treatable to help patients ovulate, get pregnant.
Absolutely. Serena.
So I feel like it's such a crazy message, because when reproductive endocrinologists like myself and Dr. Rodgers and Dr. Evans see a PCOS patient, just as Dr. Blake said, we're like really excited because we know we can help them. We know we can help them get healthier. We know that there's so many things they can do to feel better, to be healthier, and to have a healthy baby. And the overall prognosis is outstanding for these patients. So it's actually one of our kind of our favorite patients to treat, because we're usually always successful as long as the patient, kind of sticks with us. So I feel like actually the opposite message should be out there. Maybe a lot of patients cannot get pregnant without a little bit of help and advice, but with some help and advice, the vast majority of patients will be successful.
That's such great news. And thank you all for, for sharing that message, because I think it's important for people to hear, because they have girls in their teens that walk in that have irregular menstrual cycles, and they're being told, oh, well, you know what, you're probably not going to be able to have kids, so don't worry about it. I think it's a horrible message, and it's just great to hear different perspectives on this. So how can we prepare for a healthy conception or pregnancy when we have PCOS? Do we have to do things differently, or is it really the same as anyone who might be having problems with pregnancy when they come in? And Dr. Chen, I'm going to start with you.
It's kind of the same and it's kind of different. So we want everybody, really everybody, and this is not the way things work here in the United States, but what we would love, and I'm sure all the doctors here would agree, is we would love people to, plan preconception health optimization way before they conceive, maybe even 2 or 3 years before they conceive. Honestly, it's something that is kind of a journey of a lifetime, that at each stage of our lives, from babyhood and childhood through teen years and adult years, we should all try to be proactive about not only our reproductive health, but our general health, because that is going to lead to much better outcomes when it comes to having a family. And that is very true of PCOS. Now, PCOS, you do have more risk factors. So you are much higher risk for gestational diabetes and hypertensive disorders of pregnancy, and therefore significant pregnancy complications, including potentially heart complications. And of course, most PCOS patients tend to hold on to weight and gain weight more easily and have trouble losing weight despite healthy diets and exercise. So those are some really common particular challenges we see with PCOS. So we would really love for everybody to talk about pregnancy planning before you're struggling with it, even though that's not how your healthcare system is set up. And that's where organizations like PCOS Girl, Heart for PCOS, PCOS Challenge come into play, because you guys give out all this wonderful information on social media and the internet, and it helps empower people to advocate for themselves, because we do have kind of a difficult healthcare system, and you kind of have to be a nudge to get the things that you want, because we tend to just only treat people when they're already in trouble. And really, ideally, you want to treat yourself and optimize your health before you have any problems, so you don't have problems.
Right. So dovetailing off of that, Laney, you deal with patients in particular that have preeclampsia. So when someone is going in to try to conceive when they have difficulty with fertility, are there certain risk factors that they should be aware of, or things that they should be aware of to optimize their health to reduce risk for things like preeclampsia?
Definitely. And just like Dr. Chen said, with any patient who may have risk factors for preeclampsia, which can include women who are of advanced maternal age, who may have a higher BMI, who have complications like PCOS, or even patients that are going through IVF or any type of artificial reproductive technology usage. Those are some risk factors for preeclampsia, as well as family history. And if you've had something in a prior pregnancy, that's something that your doctor needs to be aware of. The best advice that we always give is to schedule a preconception consultation, either with your obstetrician or with a high-risk specialist, which is known as a maternal fetal medicine subspecialist. And if you do know that you may have hormone issues, a reproductive endocrinologist, like my colleagues that are all sitting here on this panel, just to have that conversation, get some blood work done, look at what we can do as far as modifiable risk factors, which include making sure that you're in a heart healthy diet, that you are getting exercise, whether or not you're losing weight. That cardiovascular exercise is so critical for pregnancy health in general, and especially for women who are at risk of hypertensive disorders of pregnancy. So your heart knows that you're working. And so that's the best, way for you to just kind of prepare. And as well, Ashley and I are both really passionate about the whole mental health angle, but going into your pregnancy knowing that you may not make it to a full 40 weeks, and you may have some extra doctor's appointments as you kind of go along your journey. Some in the beginning if you're suffering from infertility, some toward the end if you're having any kind of complication. But just know that those doctors and nurses are there to help you walk through that experience, and you can get through it and, you know, at the end, get the result that you want.
That's awesome. Thank you so much for sharing that. Dr. Shawn, I wanted to direct this to you because you have that integrative background. How important is lifestyle management when we're looking to conceive or throughout pregnancy with PCOS?
I don't think you need to have any sort of other background to realize that lifestyle is super important, as Serena said. And Blake, I just want to mention something real quick. I did my residency at OU, and Carl Hansen, your chairman, was my intern. So I want you to tell him I taught him everything he knows. No, the man is actually truly a genius. So I probably didn't teach him anything. But yeah, he taught me probably everything.
Yeah, he's one of my partners. I will tell him.
Tell him
that.
I said hello. And but yeah, lifestyle, I mean, you know, and I think this was touched on, obviously, you know, lifestyle management in this country is overall pretty bad. But I will also say my colleagues in general, and I'm making a grand generalization, but the main treatment for PCOS is birth control pills, right? We're not really giving them, maybe because we don't really have the time as providers. And I wish we had a different system where we could teach, you know, nutrition and exercise, but also I think, you know, genetics, looking at family histories, really diving in on, you know, psychological aspects, because, you know, why are we overweight? And it's not just because of what we're eating, it's why we're eating and the choices that we have and the food choices in this country. And there's so much information. I know Serena and Blake are out there a lot on Instagram because I see them all the time talking about, and Laura and Dr. Shine as well, talking about just all these weird TikTok trends and, you know, blah, blah, blah. Now everybody wants GLP-1s because they might lose weight. And there's different ways to do that, you know, but it takes time, right? And it takes a lot of work, and I see this probably a lot more possibly because I'm more of a frontliner than some of the REIs here. And I can tell you it's stressful because I'm kind of a pariah even in the OB community here, because I don't just put everybody on birth control pills, and I try to do other things, but you know, billing a 99213, which it's going to get me $57, and the system's broken. Serena mentioned that. But yes, I think if we could spend the time with the patients, talk to them about the lifestyle choices, even, and I tell patients, you know, even walking, just getting out after you eat dinner and walking will lower your glucose levels. We know this, but it's, you know, COVID messed everybody up, and people are just starting to come back out and getting out there and doing stuff. But lifestyle, number one, if you had a food pyramid for PCOS, that lifestyle is the bottom. You got to work on that stuff first, for sure.
Absolutely. Dr. Allison, if we're doing everything right with our lifestyle and we're taking the medications that are prescribed in hopes that maybe that'll, you know, help us with getting pregnant, and it's still not happening, what makes somebody a good candidate for reproductive technology or IVF with PCOS?
So I had the fortune of treating one of my nurses who is very open about her journey. So I feel comfortable being, you know, she's very open about it. And I've helped her have 3 of her kids. And when she first came to see me, and this was, you know, 7 years ago or something, I was like, oh my gosh, just like we talked about, PCOS, no problem. Let's give you a little letrozole, little intercourse. Everything else looks perfect. Great. Okay. And I think that, like, in young, healthy patients with nothing going on, like everyone talked about, that's the appropriate choice. But sometimes there's more going on. And the only way to know that is to try conservative treatment if you are a good candidate for it, right? You're young, you have no other issues that we think about. But sometimes there's other issues that are not obvious on testing. Sometimes your fallopian tubes are not functional, right? The fallopian tube is not just like a pipe. It is a functional organ. It has to pick up the egg, bring it into the uterus. It may not be working. We have tests for open and closed. We don't have tests for functioning. And sometimes there can be some significant egg quality issues, right? Quantity of eggs with PCOS is usually not a problem, right? One of the hallmarks of PCOS is we got lots and lots of eggs. but sometimes egg quality is an issue. And those extra eggs are not always, the healthy eggs that are going to allow pregnancy. Sometimes there's issues with the uterine lining, right? From all that extra estrogen for years and years. Sometimes there can be some abnormalities in the lining. So I think that in general, listening to your doctors and doing all the right things, always right. But even in the algorithm of doing treatment, usually, and I'm not sure what everyone else does, but typically what we say is about 3 cycles, of maybe letrozole is usually first line, letrozole with intercourse, if the semen analysis looks normal. If that's not working, sometimes we'll move it up to, letrozole or try another medication like an injectable, or there's lots obviously of different treatment choices, and add some inseminations. If that's going to work, it's probably going to work in the first 3 or 4 cycles, and then sort of bump it up to IVF. And I certainly think, and I think we'll potentially get into this, but IVF patients who have PCOS certainly face some additional challenges. And I think that the good news is that, just like we talked about, this treatment is very effective, right? And people are usually successful. And I think that it's important to just, even if some things aren't working, it can be very, very discouraging, but don't give up hope, because there is always a pathway to your baby.
Absolutely. And that's something else that I wanted to talk about. And Dr. Blake, I would love your input on this. With PCOS, even sometimes when we're successful with pregnancy, there is a higher percentage of pregnancy loss. So how do you counsel patients with this? And when they do have loss, when is it okay to start trying again? And do you encourage patients to keep trying?
Yeah, absolutely. I encourage them to keep trying. So it kind of depends on a few different things. But for one, you are correct. There is some data to show that patients with PCOS do have a higher risk of miscarriage. And what do you do about that? Of course, like we mentioned, lifestyle interventions. If a patient's overweight, reducing weight, healthy diet, those are things that can help reduce that risk. You can consider sometimes if a patient has a low progesterone, you can supplement with progesterone, although that's not kind of like an end all be all, like a tried and true, yes, this will fix everything. But if someone does ultimately or unfortunately have a loss, if it's really early, like a biochemical loss, then usually as soon as the HCG trends down to negative, it's totally fine for a patient to resume a normal cycle or try another cycle after that. And quite honestly, even if the patient's a little bit further along, and has a miscarriage, like early first trimester, same thing. Now, the only thing that would maybe delay it is sometimes I might have a patient, if they are further along first trimester, say maybe like 9-10 weeks, and they unfortunately have a miscarriage, I might want to do like a saline sonogram to evaluate the cavity, because retained products of conception are unfortunately kind of quite common whenever you're that far along. I don't know about the other physicians here, but it's not uncommon enough to take a patient to the OR to remove retained products of conception that you find like a little, piece of something on a saline sonogram. So those patients, I want them to wait a little bit longer until we get that cleared out. But otherwise, by and large, once the HCG levels go down to negative, it's definitely appropriate to just try another cycle at that point. Right.
So continuing on this theme of like prevention and pregnancy loss and things that we can do. There are a lot of supplements such as avostatol and medications such as metformin that some patients are kept on for the first trimester, some are kept on for longer. Are these okay for patients to take? I know everybody kind of has their own take on this, but I would love to hear everybody's feedback on this. Dr. Shawn, I'm going to start with you.
Well, whenever you have a pregnant patient, obviously, especially with supplements, there just isn't a whole lot of data on them because we can't do studies on pregnant women, obviously not ethical, so we don't do them. Metformin has a lot of data on it. And I remember even when I was delivering babies years ago, we would leave them on the metformin. Metformin, I believe, and my colleagues can correct me if I'm not right, but can decrease the risk of early pregnancy loss and preterm labor and things like that. So we did leave them on metformin. Now, there is data to show myo-inositol or avostatol, berberine can also help in a very similar manner to metformin without some of the side effects. Now, obviously, the problems with supplements is quality, making sure that, you know, what you're paying for is actually in the product. So it has a lot of nuances that are hard to deal with, because a lot of people want to buy the cheapest one they can find because they're already spending a lot of money and whatnot. And sometimes you're just paying for nothing. And so you really want to have good brands and good quality. And then, you know, having somebody that can follow you that really kind of knows how to work with those products, because like I said, there's a lot of nuances there. But as far as pregnancy goes, I probably wouldn't continue them just because of the liability. And I don't know. Probably they're fine. But again, we don't know what they do because nobody's really studied their effects.
Dr. Serena?
I think those are all excellent points, Dr. Chung. And I think you have to individualize, you have to counsel, you have to individualize. There is a lack of data, and the lack of data in women's health, and especially in pregnancy, is really a shame. And you know, that's one of the things that PCOS community, like Ashley and I know you're working on, and that's what we'll be working on for PCOS Advocacy Day, is trying to get more funding for research. There are some interesting studies. It's very controversial whether or not metformin or myoinositol could lower the risk for miscarriage, but there does seem to be fairly strong evidence that in people who have prediabetes or have a tendency towards prediabetes and diabetes, that those drugs can lower hemoglobin A1C or glycosylated hemoglobin or your sugar levels. There is some evidence that these drugs can lower the risk for gestational diabetes. If you are lowering those kinds of risks, secondarily, you are probably impacting miscarriage rates in a positive way. But it is very hard to collect this data. So to be able to say, oh, well, this definitely will lower your risk for miscarriage, I don't think we have enough data to be able to say that for all patients. I do think patients that are high risk for gestational diabetes, it's very reasonable to consider. I've been keeping my patients on ovasitol that have done well on ovasitol, that tolerate it well, where it seems to be helping control their sugar levels over and above diet. Like, you can't take myoinositol and then, you know, eat a bunch of candy bars. This is in addition to good sleep, exercise, eating a lot of veggies, you know, all of those kinds of things. But I have seen in a lot of my patients that when they're optimizing their lifestyle, the myoinositol or the metformin can lower their hemoglobin A1C even further than it can be done with just lifestyle alone. So I do feel it has some benefits, but you know, it does have to be individualized, and the patient has to feel comfortable with the lack of data. Some of my patients feel like, I'm doing great on this drug. I know it's going to help me. I've tolerated well, and I feel comfortable with the fact that we don't know everything there is to know. And some people really don't want to take those risks. And I think we have to be open with our patients and let them know what we know and what we don't know. So I like to individualize.
So Dr. Blake, can you talk a little bit more about the risk factors with PCOS when we become pregnant, such as like gestational diabetes? What are some of these issues that we have to be aware of?
Yeah, absolutely. And before I move on to that, I wanted to just put in a quick plug, because we keep talking about data, needing more data, and myoinositol, what we do and do not know. We are doing a prospective randomized trial at our university for myoinositol. One of my partners is leading it, Dr. Heather Burks. And so we're randomizing patients to do Femara and timed intercourse. Also, you have to make sure their tubes are open, normal semen analysis, and then randomizing patients to either placebo or myoinositol. So we're enrolling for it currently. So it'll be a decent amount of time before we get results, but nonetheless, stay tuned. Data will be here soon. So I'm super proud and excited to be working with Dr. Burks on this. So,
That's
and then
awesome.
in terms
Thank
of,
you.
yeah. Just wanted to mention that. So, and Ashley, I think I partially forgot the question you asked me now. I apologize.
I just wanted to talk about some of the risk factors during pregnancy, such as gestational diabetes, and I'm going to let Laney talk about preeclampsia a little bit more, but some of these risk factors that we have to be aware of with PCOS.
Yeah, definitely. So without stealing the preeclampsia show from Laney, so with gestational diabetes, certainly there's a bit of a spectrum with these patients. Of course, patients with PCOS that are overweight are going to have more of a propensity to be insulin resistant. If you're insulin resistant, that drives the ovary to make even more androgens than you normally would, androgens, AKA testosterone. And that kind of propagates the whole thing to having irregular cycles, thickened endometrium because the androgens are converted to estrogen, thicken the lining, risk for endometrial hyperplasia. So there's several other things, but all kind of goes to, it's just this kind of vicious cycle, like a positive feedback cycle. And when patients are at risk for insulin resistance, then once you become pregnant, the placenta starts to make a hormone called human placenta lactogen, and it increases your risk even more so just by being pregnant alone for having diabetes. So if you have a patient that's already insulin resistant or diabetic before they even get pregnant, then you become pregnant, you have HPL or human placenta lactogen, and then all of this just kind of builds onto each other, and gestational diabetes becomes an extreme concern, a big risk at this point. And so with that, of course, the metabolic concerns on the mom side of things, and maintaining a healthy pregnancy, making sure that the baby is developing appropriately and not gaining excess weight, because the baby is now has a lot of insulin that's depositing fat throughout the trunk of the baby, and the baby becomes large, and then there's problems with delivery. So there's a lot of things that compound each other, and it all starts with making sure lifestyle interventions before you get pregnant. While you're pregnant, it's not like once you get pregnant, just you have to all of a sudden now you can't exercise ever again. That's not true. And so we still want patients to continue that once they are pregnant. And so certainly a very big risk factor for those patients who have pre-existing issues before they conceive. And even patients who are thin with PCOS, they still can have insulin resistance. I sometimes feel crazy obtaining a diabetes test or glucose tolerance testing on a patient that has a BMI of 24, but still these patients with PCOS can have insulin resistance. So nonetheless, need to test these things in all patients, regardless of what their BMI is, because it has a lot of concerning issues when you become pregnant.
Right. So, and Laney, I'm going to be with you in one moment with the preeclampsia, but Dr. Allison, I wanted to ask you, because you had mentioned this before, can a pregnancy be healthy regardless of a person's size, or is that a major factor with pregnancy and trying to conceive in health?
So I think that it's really important for people out there who are listening this to understand that, the number on the scale, a BMI, it's not necessarily the be all end all of health, right? We think about risk factors, just like, Dr. Evans just said, like, you can be diabetic and have PCOS and have insulin resistance and be of normal weight, right? So I think that certainly people who carry extra weight are at higher risk for pregnancy complications. And I think that's where the lifestyle modifications really play a big role, because they are at higher risk, right? So making sure we're eating lots of, like we talked about, fiber, making sure we're exercising, because that keeps our cells sensitive to insulin. It keeps our insulin levels under control. So it's not about necessarily a weight, a number on a scale, or a BMI level, but I think that it's more about the risks for pregnancy complications. So, can people in larger bodies have healthy pregnancies? Absolutely. Are they at slightly increased risk and probably require some additional, like we talked about, like, maybe doctor's visits and testing to make sure that their baby is going to be as healthy as possible? Absolutely. I mean, at the end of the day, we all want the same thing. We want a healthy mom and a healthy baby, right? And everyone, I think, out there wants to do everything they can in their power to have that healthy baby. And so I think that that's where working with doctors and other, providers to really focus on reducing risk, whether it's being on medicine, whether it's implementing a diet or exercise program, whatever it may be, to sort of make sure that you're getting monitored and, know if you're at increased risk to make sure that you're doing everything you can to lower that risk.
Absolutely. And thank you for sharing that. Okay, Laney, you are on, girl. I wanted to talk a little bit about preeclampsia with PCOS, because that's one of the risk factors.
Definitely. And there's a lot of members of the Preeclampsia Foundation's community of survivors that are PCOS survivors as well, and, have been living with that day in and day out for most of their life. And if you think about it, it makes a lot of sense to understand that there's a correlation between PCOS and hypertension in pregnancy, because of the hormone imbalance, everything that Dr. Blake was talking about, it puts a lot of stress on the cardiovascular system, on the heart and the organs, the pancreas, all of those organs that sort of depend on us having a moderated hormonal balance. And so when a woman with PCOS does get pregnant, she needs to be aware of the signs and symptoms of preeclampsia and sort of double checking that at every pregnancy appointment that they're making sure to accurately take her blood pressure, because that's the number one way of determining whether she has hypertension. And there's been a lot of recent research evidence that shows that for women who have chronic hypertension, which is defined as either hypertension that they had before they got pregnant or hypertension that appears before 20 weeks of pregnancy, that tighter blood pressure control through medicines that are safe during pregnancy can actually help to improve outcomes both for mom and baby, which is really great news, because it means that there's really some evidence out there to support ensuring that mom is as healthy as she can be early on in the pregnancy to help that placental development and help her and her baby, as Dr. Allison said, just have that perfect outcome of healthy mom, healthy baby, because that's what we want. So during pregnancy, make sure that you're paying attention to headaches that don't go away, severe swelling, especially of the face and the hands. That's often one of the first things that people notice. And of course, weight gain and water retention is very common in pregnancy, but you can kind of look for pitting edema, make sure to report that to your doctor. Upper gastric pain. So this is like kind of basically where your liver sits that that's a sign that you may be having a very specific variant of preeclampsia called HELP syndrome that impacts the platelets, the red blood cells in the liver. Watching for decreased urination and protein in the urine, which is one of the things that a lot of pregnant women don't know. Like the reason that you pee in a cup every time you go to the doctor is actually to look for protein markers to just monitor for preeclampsia. And that also includes in the postpartum period, because just like with PCOS, there's sort of a misnomer that says delivery is the cure. And once you deliver the baby, mom will turn around and she'll be just fine. But we're seeing an increase in cases in the postpartum period. And especially for women who kind of have that constellation of metabolic syndrome or gestational diabetes, maybe at a higher BMI, you need to be continued to be monitored in the week after your delivery to ensure that your blood pressure is going the right way and that you and your baby are both healthy. So I just want to put in a plug for that too.
Thank you. So we're coming up on just a few minutes left for our conversation. So I wanted to ask each of you, why is PCOS awareness so vital, not only for infertility, but for our overall health? So Dr. Allison, I'm going to start with you again.
So because PCOS is so common and it's often misdiagnosed, I think that there's lots of times where people go get help for periods or, symptoms of acne or, weight gain, other things, that it's not necessarily diagnosed or not diagnosed properly. And we know that having PCOS increases the risks of some, really serious medical conditions, right? Long term. So we talked about it, cardiovascular disease, of course, big one, the high cholesterol, diabetes, right? And I think that it's really just so important to make sure you're advocating for yourself, like Dr. Chen said, and that you are, that we're getting the word out there, so that if you're worried, listen, I have a lot more acne or hair in places I don't feel like I should have it, or my cycles are irregular. And, it's important to advocate yourself, to get evaluated, and to get connected with a doctor who knows about PCOS and can evaluate you and treat you. So your short-term and long-term, we're not talking about just fertility, but right, like short-term and long-term health risks are addressed.
Absolutely. Great points. Dr. Shawn, what do you
Sorry,
think?
I muted myself, which
You're fine.
probably everybody was hoping for that. But I would say I just want to rebound off what Allison said. So many women are diagnosed with it that don't have it, and so many women are not diagnosed with it that actually have it. I kind of feel like PCOS is, for a lot of providers, is just like throwing darts. Like, oh yeah, you missed 3 periods, you got PCOS, and let me put you on a birth control pill. We have criteria, the Rotterdam criteria. It's a little sparse, but it's at least a guidepost for some folks with elevated testosterone. You can also look at FSH-LH ratios, insulin, glucose, ultrasounds. There's so many tools we have now to actually make the diagnosis, but then to also not just say to the patient, hey, you have PCOS. Let's help them with the PCOS. Let's start working with them so that they can get pregnant, so that they and not just tell them, oh, if you just lose 30 pounds, well, it'll go away. Because I hear that all the time too. And the advocacy thing that Dr. Chen talked about, it's true, because if you get diagnosed with PCOS, there's nothing wrong with you asking why. Well, how did you come up with that? Why do you think I have it? What made you come to that? And then, you know what? I don't want to go on a birth control pill. I want to try other things. What else can you help me with? And if they kind of blow you off, well, find somebody that will help you. There's multiple docs out there, like everybody up here, that will spend the time with you to work with you so that you can take charge and do the things that you need to do. But yeah, if it feels weird to you that somebody just told you that after seeing you for 2 minutes, then maybe you should investigate it. Or if you have done your research because of advocacy, like with what you're doing, and you really think you might have it and people are blowing you off, find somebody that will do the extra testing or that will spend the time with you. So advocate.
Absolutely. And I'm glad you brought up about the criteria, because they are actually working on updating criteria right now.
I thought that was coming out like now. I thought it was pretty close.
Very, very close. Yes, it's supposed to be coming out very soon. So I'm really looking forward to seeing it and seeing if it includes some newer diagnostic criteria. So
I hope so, because there's only 3. There should be a few more, but
we definitely do. Dr. Blake, what are your thoughts on this?
Well, you guys have already made so many good points. You're just not leaving me with many left to say. But one thing I will say that I definitely want to mention in terms of advocacy, because PCOS is so common, the time to pregnancy, I feel like with some awareness of PCOS and getting into a doctor at the appropriate time, I feel like time to pregnancy could be shortened for a lot of people. I can't tell you how many times I have patients come in like, yeah, I've been trying to get pregnant for 3 years. I have periods every 6 months. But as you start to go through the pathophysiology of PCOS, you kind of explain to them, well, when you're having a period, it's not actually a period. It's probably just breakthrough bleeding because your lining is getting so thick and it's brittle, starting to break down. But nonetheless, they also will say, yeah, I try ovulation predictor kits all the time, and I spend billions and billions of dollars on them. And then in my mind, I'm thinking, okay, I need to talk to this patient about how we generally don't recommend doing ovulation kits when patients with PCOS. And I do have a video that I've made that's on my Instagram that talks about why, but these in patients with PCOS, their luteinizing hormone or LH levels are commonly flat throughout the menstrual cycle. And oftentimes these patients have false positives just all the time. So you take a cycle day 1 or early in your menstrual cycle, you do an ovulation predictor kit, and it's going to turn positive in some of these patients. So then they think, I've got to have intercourse now. And so the timing is off with a lot of these patients with PCOS. Now, not everyone. There are different types of PCOS. Some patients actually ovulate on a fairly regular basis, but nonetheless, in general, LH levels can be pretty high in a lot of these patients and flat, and ovulation predictor kits are not recommended. And so with advocacy, self-awareness, getting these patients in to see doctors who know a lot about PCOS and specialize in it can help these patients become pregnant more quickly than they would have if they didn't know anything about PCOS. So I just wanted to put that plug in.
I love that. And Dr. Serena, I feel like you and I have been pounding the PCOS advocacy pavement for a long time together.
Yeah.
So I actually wanted to change the focus of you answering the question a little bit. Why is it so important for patients and providers together to both share our voices on like a national level? I think you know where I'm going with this, right?
Well, I'm hoping everybody signs up for PCOS Advocacy Day. Ashley's gonna, I'm sure, put the links in her in all our material. And of course, if you follow her and follow all of us, we will be posting about PCOS Advocacy Day. We're seeing issues on both the patient and provider side, like people suffering, as Dr. Blake said, for years, not realizing what was going on. And many patients going to their doctors over and over and over for years and the doctor never diagnosing their problem. And this is multi-layered, is because there's not enough information, there's not enough training of the medical field, it's not enough time that people are given to be able to see their patients or talk to their patients. So to really optimize care for PCOS, you need an educated provider who specializes, but you also, most of the work is going to be done by the patient, because you have to take that information and you have to bring it home with you every single day. And I think the important thing to remember is that because the technology is so advanced, the overall prognosis for you to have a healthy baby and a healthy child and a healthy body and life is very, very good. But it's not going to happen in one doctor's visit. It is going to require ongoing care. And, Dr. Blake, Dr. Allison, and I have, because we're reproductive endocrinology and fertility specialists, we have the tools basically to make a baby for anybody. But not everybody should, not everybody should have a baby, and not everybody wants a baby, but the tools do work. You just may not always want to use the tools that we have or that we recommend, because we do some crazy things, donor eggs, donor sperm, gestational carrier. There's some really advanced technology out there. Most people can get pregnant with their own gametes, but a lot of times it can be a slog. You might need 3 to 6 cycles of Clomid. We probably wouldn't go to 6 unless you're very young. You might need, even if you make a lot of eggs, you may need multiple cycles of IVF, even if your overall prognosis is good. So persistence, and positive persistence and optimism, I think, are critical. A healthy mind and body are critical. And in order to have a healthy mind and body, I do think you need to be informed and to be able to take your doctor's advice, absorb it, know when it's good advice, and apply it to your lifestyle. So there's a lot that goes into that. It's not just going to be one pill or one doctor's visit. Actually, I rambled on and on and on, and just like Dr. Blake, I'm not sure that I actually answered your question.
No, you did. And
okay.
And I'm going to have Laney focus on another area of this, which is how patient organizations play a role in helping with advocacy and helping patients find support and their voices.
I am so glad you gave me that question, because that was actually what I was going to draft off and talk about anyway. So the way that Ashley and I met each other is both of our organizations are part of a program called Mama's Voices, which is a coalition of maternal health organizations for all kinds of conditions: preeclampsia, PCOS, placenta accretia, AFE, lots of things that affect women of reproductive age and long-term, because I think it's important to recognize, like, PCOS is something you live with your whole life. Hypertension can be that way too. And we have a training program that actually can train you on how to effectively tell your infertility story or your PCOS story or your preeclampsia story, whatever that journey may have been, to then use that for advocacy, like opportunities like PCOS Advocacy Day. And we have basically really wonderful representatives that will walk you through a self-paced program and teach you how to effectively tell your story, how to make sure that you're ready to tell your story, because of course, emotional readiness is really important too, and just help you to be prepared and to use your platform to advocate, because the more voices that we have raised to help combat some of these myths that we've talked about tonight, the more likely it is that someone in your network is going to hear it and find comfort. Literally 2 weeks ago, my dad texted me about a friend of his that's like in between mine and his age. And she was just diagnosed with PCOS. She's probably in her mid 40s, past when she wanted to have children. And she's going through a lot of health issues. And he was like, hey, I know you've done a few things like about PCOS. Could you talk to her? And thankfully, I was able to connect her to the organization PCOS Awareness and PCOS Challenge, and get her some support in a time of life where she's really struggling and didn't know anyone else who was going through this. So never underestimate the power that just your voice amplified can make. And I hope that's a nice note to end on.
It is. It was the perfect note to end on. Everyone, you are all amazing, and I could do like 10 hours with each of you on all of this. And I'm sorry we didn't have like a ton of time to really dive into a lot of this, but I want everyone to know how to find all of you. So I am going to share all of your links and all of your information, but real quickly, if you could just tell people on like Facebook or Instagram, if there's a quick way that they can connect with all of you. Dr. Allison, I'll start with you.
Okay, you can find me at all the platforms, but mainly Instagram and TikTok at dr.allison.rodgers.
Okay, Dr. Blake.
Mainly on Instagram at Dr. Blake Evans is where you can find me.
Okay, Dr. Serena.
Mainly on Instagram, a little bit on Twitter and LinkedIn at Dr. Serena H for high maintenance Chen.
Laney.
You can find the Preeclampsia Foundation on pretty much every platform. We have a really robust Facebook and Instagram. Instagram, we're at preeclampsia.foundation. On Twitter and Facebook, it's at preeclampsia. And we've just unveiled our TikTok channel last year, at the end of last year. So like, come find us on TikTok. You'll see some really fun things about hypertension.
Awesome. Dr. Shawn.
I just wanted to say, Serena said they all know how to make babies. I have 4 kids, so I know how to make babies. Just on my own. But I'm at Shawn Tassone, SHAWN, Shawn Tassone, MD.
Awesome. And I just wanted to give one more plug here, because there is a new organization that has come out, which is really helping patients get access to care where they may have difficulty getting access right now, which is Doctors for Fertility. So I would love you guys to just talk about that real super fast and just let people know how to connect.
Thanks so much, Ashley. Dr. Blake and I are both at part of Doctors for Fertility. Dr. Allison is also a supporter, although not officially on the board. We'd love to welcome everybody. You don't have to be a doctor to join, but with the overturn of Roe v. Wade and the passage of the Dobbs decision, we are all seeing significant challenges to pregnancy care. A lot of these laws say they're trying to control elective termination of pregnancy, and what we are seeing is a really negative impact upon doctors' abilities to take care of their patients, mostly pregnant patients, female patients, but we know if we are threatening to throw doctors in jail for taking care of patients, we're going to impact the entire healthcare system. So Doctors for Fertility is working hard to try to educate legislators, patients, physicians, and trying to keep access to reproductive care safe and open for everyone. So across all the states, and we can definitely use some help. So we'd love for you guys to check out Doctors for Fertility, FOR Fertility on all the platforms. We're doing fundraising. We'd love for you to be a member. We've just started our training programs like the Preeclampsia Foundation to help you tell your story and give you a voice, because we know that the silent majority actually wants doctors and patients to be making healthcare decisions and does not really want politicians to be making these decisions. But since we're not usually politically active, we all need, we'll need a little help. And that's what we're here for, to help people advocate for that. So thank you so much, Ashley.
You're welcome. And everyone, thank you again for joining me this evening, for sharing your expertise. You're all amazing people. I want to remind everyone that we still have at least 2 weeks left of interviews, of lives, of events for Heart for PCOS. So please be sure to tune in to all of our channels on Instagram, Twitter, Facebook, and YouTube to access all of this great information. And also, I don't want to forget to remind all of you, if you're frustrated about PCOS, about the lack of research, the lack of information, the lack of care, do something about it. Raise your voice, stand up, join PCOS Advocacy Day on March 2nd, 2023. It's virtual, so you can stay at home with your fuzzy slippers on and advocate with Congress. So please come and join us. There will be more information in the links for this video. And again, I will share everybody's information so you connect with all of them. Have a wonderful night, everyone. Thank you, and see you all again soon. Bye-bye.
Thank you.
Thank you so much. Bye, everybody.
Thanks, everyone.
Ashley, you're doing an incredible job. Thank you so much. This
Thank
is
you.
so